we're going to go into the perineum pelvic floor. We'll go over the urogenital triangle. We'll also talk a little bit about the ischioanal triangle. These are extremely important markings of the human body, especially when you're thinking about labor or delivery and the overall pelvic floor health. We'll talk a little bit about vasculature supply and also innervation. So we'll start by talking about some of the boundaries that share the contents of the perineum pouch, and then we'll talk about the clinical significance, especially injuries, right? So when you get into a car accident, or if you were to rupture your bladder, or if you were to have a fracture of the pelvis, what could that implicate, right? So let's say the bone fractures and it penetrates inwards toward the structure. We'll go over some of the landmarks of the perineum. We'll talk a little bit about the deep perineal pouch and its contents, and then we'll also look over some muscles. So in today's session, there will be another 2 to 3 charts of muscles that goes over some of the major urogenital pelvic floor muscles, cavernosus, bulbospongiosus. We'll talk a little bit about the perineum, the transverse perineum, but these muscles uphold the triangle frame of your pelvis, right? And again, when you think about pregnancy, think about labor, delivery, and Kegels and strengthening the pelvic floor, that's what we're going to focus on, okay? And then let's go ahead and get started. So for the first intro to this topic is we're going to begin by looking at what the perineum is. So for those, the perineum is this external surface area that is created when you lie down and you raise up your legs, and then you look into literally the ischiotuberosity or the buttocks, right? You look at the leg raised part of the body, and it's an unusual part. You know, you don't usually see it unless you're on a medicine bed or a lying table. But you'll see right here, there's a couple of structures that demarcate the interior triangle, and then on the posterior side, you can make another triangle. So I'll draw it out. But if you look at this picture on the right, you should clearly see that in the superior portion of this image, you have the pubic symphysis, and that pubic symphysis is the juncture of your pelvic bone. You create a triangle, and this triangle is called a urogenital triangle. The two edges of the lower border of the triangle are going to be their ischiotuberosity, right? That's what part of the pelvic bone you're sitting on. And so you have this triangle creation. And then within this, there are going to be several muscles, and for the male and female, there's going to be a slight difference, right? You have the clitoris for the female, and then the scrotum, the penis shaft for the males. And these muscles uphold the ability to maintain erection, to provide continence. That's kind of the theme today, is that when you hear about patients that have incontinence, where they don't have the ability to properly control urination, or they just can't control and just leak, or defecation. And that's usually a result of weakened pelvic floor muscles. It's hard to pinpoint exactly which one because some actions do overlap. However, we're going to go over a couple muscles where they have the major primary action, and those primary actions are the ones that are like 80% responsible for upholding the continence. Okay, usually it's the cavernosus or even the levator ani. So those two muscles play a big role of the lower frame. And then this is also a common practice where if you are, after birth, after you've given labor naturally, and no C-sections, after you've given birth, there's oftentimes a lot of changes for the first couple of weeks to how you would defecate and urinate. And the pain that accompanies it is usually because of weakened pelvic floor. Okay, so this is why it's very important when you're strengthening, or if you're trying to anticipate pregnancy, to develop some nice, stronger pelvic floor muscles, Kegel exercises, kind of squeeze, and you practice that as a kid growing up, right? Just whenever you're sitting on the toilet, you're activating those muscles that strengthen the floor. Okay, and then on the posterior side, if you look at the picture, we have the uroanal triangle, right? So you form another triangle shown in blue, and this is where you have the bottom end of the coccyx, and then you have the sites of the gluteal fold included, and on both sides, you're also going to have the ischiotuberosity. So it forms a diamond shape. So altogether, it's like a diamond. And this region is important, especially for pelvic floor health. And if you have pelvic fractures, if you were to have a ruptured bladder, if you were to have labor, any of those conditions will be extremely relevant to maintaining the health of this area. So we'll start off with some anatomy. So a few things to point out. And again, for this point, I've tried to make it where every time I give you the PowerPoint, I will highlight what I really want you to look at. So what I want you to know, and terms and bold. Just be mindful when you're looking at the picture. So on the first couple of osteofibrosis boundaries that we have, so these are all bone markings. There shouldn't be anything brand new. These are just bone landmarks that are the boundaries by which the perineum sits. So you have the pubic symphysis, that's the most anterior when you lie down, or the most superior region. We have the inferior pubic and ischial rami. And of course, the bottom edges, we have the tuberosities, the ischiotuberosities. We also will have the sacrotuberous ligaments. This is also within the boundary. And then in the inferiormost, we have the sacrum coccyx. Okay, so these are the key markings. When you look at the pelvic bone, what kind of borders that zone? And obviously, depending on the physiques and the different kind of body types, patients will be different. It might be harder to be able to pinpoint exactly the location, and then the width, and then the height of that triangle. Within the anal triangle, it doesn't contain a couple structures, so the anal orifice and then the anus. We went over the rectum briefly last 2 weeks ago, right, when I showed you guys the transition from the descending colon, the sigmoid colon, and the rectum. We'll go over that again because it's part of the musculature. And then in the urogenital triangle, we'll abbreviate that as UG. UG means the urogenital region. It's going to contain, for the males, the scrotum and the penis, and then for the females, the vulva. Okay, so again, we'll, at the last lesson or last module for this course, we'll go over reproductive system, but just be mindful that the external genitalia are different, even though in an embryology standpoint, they came from a similar starting point, but that final form is different, right? You have the mons pubis for females, that fatty eminence. We then have the labia majora minora, and then you have the clitoris. Versus the male, you have the scrotum, epididymis, the shaft, and the glans penis. So again, analogous structures, but final form is different. So over here on the right, this is a good picture. I like this one because it just shows you the bones. And when you look at the bones, you can clearly see the pubic symphysis being the top border. On the bottom, we have the coccyx, and then on either side, we have the ischiotuberosity. Okay, so those are the 4 key points that you should be able to, in some cases, be able to visualize. And then and we talked a little briefly about the digital rectal exam. I know I talked about it very briefly in terms of when you do an assessment, right? So when you go into a GI doctor, or maybe you have some kind of hemorrhoid, or if you have some kind of bleeding from the rectum region, how would you assess it? Like, one of the common approaches is called DRE, digital rectal exam, DRE. And when you put your finger into the rectum, about 2 to 3 centimeters, you can palpitate around the region, the orifices around the anus. You could palpitate for swollen lymphs. You can palpitate for a male getting close to some of the glands. You can palpitate, and especially when you have swelling involved, that's usually the first sign that you could assess. Okay, so again, if you've never seen it, the patient will lie down sideways on one of those medicine beds. Physician will take their glove, and then they will just insert a finger into your rectum, 2 centimeters in, and you can palpitate the swelling of the lymphatics or the glands. I think I have one application for that today, so we'll talk about that. Okay, so over here, keep going, the perineum body. So we'll talk about some of the key muscles. Several muscles are going to be within here for sites of conversion, and what I want to highlight is the perineal body. This is a region where most of these muscles are going to line up to, and because it is diamond-shaped, 2 triangles added together, these muscles are going to span from the lateral borders towards the medial border, and then from the top down. But a couple of these muscles, I'll have the key O's and I's in a second, and I'll also list out the key action. The good news is majority of all these muscles share the exact same innervation. They're all pretty much pudendal nerve, S2, S4. That's the easy part. They're all pretty much S2, S4. The hard part is obviously the ones that are either superficial, that you got to know which one's deeper, which one's on the outer side. That's a little bit tricky when you look at pictures. Okay, so let's take a look on the right side first. So we'll have the male image. I'll zoom in just a little bit. Okay, so we have the male on the left and then female on the right, and you can see that these muscles outline over the genitalia in different structures. So for the male, it covers over the crust of the penis on both sides right here. It also touches the corpus cavernosum, so that spongy tissue. And then for the females, it upholds the clitoris. And then on the lateral side, you also have the vestibule. Okay, so the glands, vestibule, and these vestibule glands help secrete lubrication to neutralize any acid. It gives it moistened textures during intercourse. But the core, right? So if you tease off all the muscle and the fascia, at the bone and the organ level, it's going to be different. And then if you look on top over here, again, you'll also see a slight difference. So you have the anus and opening. And then over here for the female, we're going to have the vaginal opening. And then we also have the urethra, right? So urethra in the front and then the anus. So again, it's slightly different. But the 6 muscles that we're going to highlight, bulbar spongiosus, external anal sphincter, EAS. This is actually typo. So superficial and deep transverse perineum muscles. There are 2 of them. And then the external urethral sphincter and then the levator ani. Out of all these muscles, I'll probably just circulate. The levator ani is the one that's mostly responsible for incontinence. So when you hear about patients getting older, and then my grandfather just can't control his bladder and pees his pants, and unfortunately, as we age, there's going to be a time where those muscles weaken. The one muscle that usually starts the cascade is the levator ani. It's shared in both males and females, highly responsible for continence. And then for the defecation, which one do you think would be the one out of this list? So that's urinary incontinence, right? That means you're having issues controlling your bladder and the urine leaks out, right? It's not really a bladder issue. The bladder just fills up the urine. Then there's a drainage for the urethra out. So what's maintaining you from not peeing your pants is you have the external and the internal anal urethral sphincters, right? So you have the internal one that parasympathetically controls. External one is the one that weakens parts to the levator ani. And then as that gets weakened over time, you tend to leak. So which one is for the anal, for defecation? Yeah, that for that one, it'll be the EAS, the external anal sphincter. So for patients that have issues and they tend to not be able to control defecation response, then that might be a weakening of the EAS. But it could be really any of the muscle or combinations, right? That's all in the pelvic floor. So that is one scenario. And another one here is I want you to think about this. So when you think about the muscles, and let's say you're a female and you're excited to give birth, and then you have to go through episiotomy, right? How would you dissect and open up the vaginal canal so that you retain the integrity of all the muscles? You don't want to cut down against the fibers, right? You wouldn't want to trim against the grain of fiber. So would you perform the episiotomy down this way, or would you go laterally, right? So those are some thoughts to think about, and that's applications. Okay, oops. All right, so over here we have some fascia. So starting with a little bit of external membranes, so we have the superficial fascia. This is going to be mostly fat membranous layer. So when you look at a patient, you're going to have this layer of skin and a lot of fat tissue cushioning this region. Then we dig deeper, we cut in, we can dissect into the first layer called the membranous layer. This is also known as the Colles fascia. Colles fascia. This is the first layer. This layer surrounds 2 structures that are different for males and females. For the males, you have the dartos muscles, which literally is what? And for guys and males in the room, what happens when it's really cold and you're showering? What happens to your scrotum or your testes? Shrivels. Okay? It doesn't really shrivel. It's actually being elevated towards the body. All right? So if you don't know, it's not getting smaller. It's being elevated towards the body of the torso. And the muscle that raises it up is the dartos. Okay? That's the muscle that actually pulls it up. If you don't know what I'm talking about, try this when you go shower tonight. Blast on the cold water and just assess your testicles, and then you'll see that, oh my gosh, it's coming towards my body, okay? All right, so this is the first one. Then for the females, this is going to be the layer that's sitting around the mons pubis, the fatty layer, so it's a little bit different. And then if you dissect below the Colles fascia, then we get to the deeper perineal fascia. This is called the Gaudet fascia, and then the Gaudet fascia is where you have muscle. So at this layer, you have some of the muscle structures that you can see. The 3 that I want to pinpoint is east cavernosus, bulbar spongiosus, and then the transverse perineal muscles. These 3 are probably the more external layers that you'll see, and they will then directly attach into the ligaments of your gonads. So for the male, it binds to the shaft of the penis. So that's why when you think about erection, maintaining erection, or if you have ED, a lot of folks when you get older, you know, and let's say you have injury in the pelvic floor, and for males, let's say you're having erectile dysfunction, right? It's an issue that happens, and it starts to become more prevalent as you age. It could be a weakening of these muscles, okay? And oftentimes, cavernosis, bubble spongiosis is what maintains the erection and for the ability to penetrate. All right, so that is the visual. So let me show you the visual here. On the right side, we have the comparison. So you have the female on the left and the male on the right. Some of the images, they keep flip-flopping the gender, so I apologize if that kind of throws you off a little bit, but you can see right here for the females, you have the uterus right here. The bladder sits on top of it, urethra exiting right here. Let me use another color so it's maybe a little bit more visible. Is it red? So you have the bladder, the urethra exiting, the uterus right behind it, vaginal canal, cervix comes in, anal canal over here. So all the structures that we're referring to here are mostly on the interior triangles, right? This is in the urogenital triangle in the interior region. For the male, it's a little bit different, right? So over here, you can see, let's say you take your finger and then the doctor is assessing with the DRE, the digital rectal exam. So what can you palpitate? Your finger goes in right here. You could palpitate for some of these green lymphatic nodes if they're swollen. So if you're infected or if you have this crazy infection or bleeding occurring, and in some cases, I guess, you know, one of the worst case scenarios, if you think about it, is extravasation of blood or urine. So imagine you had a really bad accident, okay, and then you fractured your hip. The hip bone lodged into the bladder, causing your bladder to leak into the lower GI or the lower abdominal region. So what happens is you might even have urine or blood accumulating in some of the fascias. So these two membranes here, guys, the membranous membrane, the Colles fascia and the Gaudic fascia, in worst case scenarios, you could actually have fluid accumulation in those areas. Okay, and that's usually like a worst case. Like they go in and, oh my goodness, there's blood or accumulation of urine trapped in the membrane. That means there's some sort of puncture. Okay, and then for over here, just showing you the males, we have the dartos muscle surrounding it, this thin layer, and this is going to be directly linked with the Colles fascia. All right, so that's dartos muscles that we talked about. When it's cold, contracts and pulls it up. Okay, so let's go over some of the superficial pouch, males, females separate, and then I'll show you the pictures on the right so you can see it's a lot of stuff going on. And these images are good in the sense that they're comprehensive, but they're not good in the sense that it's a lot going on. Okay, it's very busy. So take some time to look at it, and I'll circle a couple of the key structures to look at. So we'll have over here the males, the main superficial perineal pouch is going to include all of the attachments for the east cavernosus and bubble spongiosis. It also will have some of the branching of the supply of the vessels. So you're going to see mostly the S2 to S4 of the pudendal nerves. You also have the internal pudendal vessels that come in. And then for the females, the major structure is going to be the clitoris and its cavernosus. Okay, and whenever there is a rupturing or a direct damage to any of this deeper fascia within the Gaudic fascia, most of the time, these muscles are going to be weakened. All three. Okay, it's hard to just isolate one muscle and say, okay, well, the other two are still functional. Whenever the Gaudic fascia is compromised, the muscle isn't weakened. As a result of the weakness, then you're going to have ED or maybe incontinence or maybe just uncontrolled bladder and you're leaking urine. Okay, so it's kind of a chain effect. So that's one way to pinpoint it. And then for the females, it goes and binds the clitoris, and then that's linked directly to the is cavernosus, as well as the vestibuli that binds the surrounding muscles of the bubble spongiosis. All right, and then also same thing, the nerves are the exact same, pudendal nerves S2 to S4, and then we have the internal pudendal vessels. Okay, so just a visual to show you, and I'll have some cadaver images as well to show you the perineum, because this is one where in a cartoon image, it looks perfect. It looks really asymmetric. The sizes, clearly see the prostate's bigger than the smaller other global urethral glands, but in a real cadaver, there could be a lot of asymmetry, swollenness, masses that you might not expect. All right, let's keep going. All right, so over here, Going over into the deeper pouch, a few things I want to pinpoint is for both sexes, they share a couple things. You're going to have both males and females the exact location for the external urethral sphincter. They also have that urethra joining for the bladder, so those are shared. The main differences in terms of what binds to where is going to be within the deep transverse perineal muscles because of the shaft of the penis versus the clitoris, right? So there's a size difference there, and also just the structure itself. And then also the glands. Okay, so for the males, we're going to have the bulbal urethral gland and the prostate glands. And those glands have a different function than the vestibular glands for the females. Over here, we'll also see a slight difference in the neurovascular structures to the penis versus to the clitoris. Okay, so that's going to be some slight variations between the two. But other than that, most of the structures are going to be shared. All right, good. Okay, now here is a picture that's pretty interesting, a sagittal view between the male and the female, male on the bottom and the female on top. And you can see how the muscles surround the organ. Okay, so this is an example. This is with all the stuff trimmed off. On the image here, I'll again change the color to blue. This big tube here is going to be the vagina, and you can see the external urethral sphincter. This is a round circular muscle that wraps around the tube of the urethra. So when you look at a picture, in most of the images that I provide you, it's always going to be just a little hole. It looks like a circle, and you can't see the entirety of the muscle. So just be mindful that the EUS, EAS, these are tubular muscles. They actually wrap around the tube. So when you cross-section and cut it, it looks like a little circle, okay? Over here on the bottom, you see the male counterpart. So over here, we have the prostate gland, which you can palpitate. So again, when you go for male, going for DRE or digital rectal exam, one of the benefits is that's one of the classic ways to assess your prostate before PSA. So years and years ago, before they knew about the PSA and the prostate antigen and knowing that there's overstimulation or overenlargement, the easiest way is to go in and just anteriorly palpitate. You would take your finger anteriorly bend towards the pubic symphysis, and you can palpitate for the enlarged prostate. Okay? And it's right here. So literally you can see it sitting right next to the EUS, and it compresses on the urethra. And this is also why when there is issues with the prostate, oftentimes there's also going to be highly chance of incontinence or blockage of urine. Okay, but if you look at the picture, pretty clear, right? You can see you have the anus right here, the rectum, and then you have the superior valve, inferior valve. And if you were to put your finger in, you could palpitate for that purple structure right there. Okay, that's usually one of the main goals. Okay. So over here, one of the clinical applications, and I want to give you a scenario, and this is a little bit more interesting, I guess, when you have an injury. Okay, so there's two injuries that could occur, and the two classifications is when you have a general pelvic girdle fracture. Again, different grades, but when you fracture your pelvic bone, something's going to happen, right? The bone's going to chip in, or you have a fragment that cuts right into the organ, punctures the bladder. And one of the common outcomes of the pelvic girdle fracture is what they call extravasation of the urine and the blood. Oftentimes, what you're going to see is that deep pouch that I just went over is where the blood accumulates. Okay, so it's going to swell up, fluid accumulates over there, and they can detect urine and blood. Another one, which is more tragic, and I'm trying to think if I didn't want to put any pictures to show you this. You know, it kind of gives you a little bit of a cringe moment, but I'm sure you've seen those videos where somebody's skateboarding or biking and they jump onto a rail, and then they land not onto the ground, but they land onto the rail, right? You've seen those before? I don't know. I've been getting a lot of those, maybe little reels or TikToks, but the kid goes onto the skateboard, right? They do a little jump onto the rail. They're trying to grind down the rail, and then right before the board flies off and they land, right? So imagine you land on a pole, and then you rupture the bulb of the penis, okay? In this case, you can see right here the blood pooling. So in the first letter A, you can see that the blood pulls into the deep pouch. So all this red stuff right here is all blood. Okay, so it accumulates, and again, it's going to cause swelling occurring, and that can cause discharge and changes to the urine. And then eventually you might even have some blood in the urine. So that's the first one. On the right side, if you were to have a complete or rupturing of any part of the penis shaft right here, so it breaks open right here, there's a little rupturing. Then what happens is urine will then puncture into that perineal space and drain into the scrotum. So these are some of the worst case scenarios, and that's why in these two injuries, it's very common that you might see some of the blood or the urine accumulate for the male into the scrotum or maybe even into the interior regions of the abdominal wall. Okay, so two kinds of injuries to be mindful of. They call it the pelvic girdle fracture and then the rupture of the penis bulb. So why is this important? When you read later on, when you go into medical school, as you're reading a board style question, they usually will give you an injury or some sort of a diagnosis. Okay, and then the patient or 18-year-old male comes in. So he's an X Games athlete and tragically suffers a rupturing of the bulb of the penis. Then you should know that, associate that with extravasation of potentially blood or urine in the scrotum. Okay, so there's things that kind of link together that makes it connected. All right, so let's go over some muscles. Okay, so this is the anatomy portion, and I'm going to go over the key muscles you need to know. There's, again, two charts I'll highlight. I do want you to know the action. Okay, action is very fair. The nerve is easy because it's all pretty much S2, S4. So I will not use in a question just the nerve and ask you the muscle because it could be any of them. I'll always give you two. Remember, whenever I have the muscle questions, I'll always give you two clues or two, little stem or hints for you to identify the structure. Okay, so the key function of the pelvic floor muscles is to support the organs, control defecation, control urination, and then also some of the reproductive processes. So we'll start with the first set here. I'll show you the pictures in a second, but I want to go over each of them and then make sure you focus on, I think for this set of muscles, the O's and I's are very straightforward. So that's why I highlighted them. So for this one, please know your O's and I's. I will use an O and I on the exam, and definitely make sure you know the action. Whenever you use other sources, the actions might be a little bit more detailed. You might get a lot more longer sentence. So I try to make it nice and short. Okay, so if you're making note cards or if you're trying to study a cheat sheet, you have it right there. Okay, but if you want to deep dive into all the synergistic actions, there's a lot of overlap. The first one in the anal triangle. So we're going to work our way from the bottom up. Anal triangle up towards the urogenital triangle. We're going to have the coccygeus muscles. And this one's basically near the coccyx region. And the main function is it's a supporting muscle. It doesn't really have any contractile function. It's more for support. So we'll call that kind of a supporting viscera of the pelvic, or supporting pelvic viscera. And we'll just use the word support as a non-major contractile function. Okay, so this is a supporting muscle. So action is, if I were to say in this injury or they fall posteriorly to sit down and one of the tailbones got fractured, then you should know which one is compromised. The O is very clear, the ischiospine, and then the insertion for this bone is the sacrum. Okay, so whenever a patient has a fracturing of a tailbone or the sacrum gets dislodged or chips down, this muscle is compromised. Out of all the muscles that we're going to go over today, the only one that has only the spinal nerve innervation, or basically S4, S5, is coccygeus. Everything else you'll see over here is all S2, S4, pudendal. Okay, so the nerve part, fair game, super easy. The next one that we have is EAS, external anal sphincter. Major function is to close and dilate the anal opening. Primary function is to control defecation reflux. All right, and then of course the O's and I's, because it's a circular muscle, it's not just like a structure that it binds to, it wraps around the tube, right? So the anus and the rectum is a tube, right? It's a food tube. So that muscle wraps around like a rubber band. Okay, so that's why I have the anal opening. The next one I'll put a star to is the levator ani. This is the one that's primarily responsible for urinary control. Okay, so again, if there's one thing you can remember for today's session, is in folks that have urinary incontinence. As you get older, as you just can't control your bladder, it's not really the bladder the issue. It could be easily the pelvic floor. And that's what's causing the discharge of the urine. And then this is a group of muscles. There's a set of muscles that we'll go into, but they basically attach to the interior and lateral parts of the pelvic region. So they're all over the place. Again, S2 to S4 pudendal nerve innervation. The fourth muscle that we're going to have here is the iliococcygeus. It does have a little bit of an overlap with the coccygeus muscle. Main function is for support. It does not have any primary contractile motion or to relax. The main function is to support the viscera. O's and I's real quick here. The O is going to be the pubic symphysis in the ischiospine. And then the insertion is the coccyx. The nice thing here is if you look at the picture, or sorry, the chart, the last three muscles I have all have the same O's and I's. Okay, it makes it nice and easy. So there's a lot of easy overlap. I try to organize it so that when you're studying this or trying to memorize it, you can group them together. Okay, put them together so it's easier. The fifth one over here is the pubococcygeus. So it's going to be towards the pubic region. It spans over from the pubis all the way down to the ischial spine for the O's and I's. Also plays a role for supporting of the pelvic viscera. Again, pudendal nerve. So I would just link these two together. Iliococcygeus, pubococcygeus. These are smaller muscles, most support functions. And then the last one here is the pubal rectalis. This one's one that's harder to see, very deep within the pelvic floor. This one directly upholds. If you recall, a few weeks ago, we went over the rectum very briefly, and I'll have a couple of slides dedicated to that again. But there's a little juncture called the anal rectal juncture. Anybody remember that? So there's a sigmoid to the rectum, and then as the rectum comes down, there's the anal to the rectum. What's the function of the anal rectal juncture? Anybody? What's the function of those valves in that little curvature? This was 2 weeks ago. Anybody? What's the function of these? Why does it need these curves and these valves? What's a benefit? Surface area. Okay, that's one way. So you can hold more feces, right? But also, you can control it, right? You don't want just feces leaking out, right? So the sphincter is what closes the door, but as you accumulate waste, you got to have a little curvature or valve to keep it in there. Otherwise, it's just going to pile up, and then your muscle's going to weaken, and you're going to just defecate. Okay? So, again, the anal rectal juncture, if you don't remember this was I had a slide image where I showed you like kind of the mapping of how it curves over, and that little curvature with the valve. There's a superior valve, middle valve, inferior valve. That's important because it helps you retain the fecal matter. Okay? It gives you a little bit more control. Okay, and then again, it's also the S2 to S4. Okay, so these are your first 6 muscles that you got to know in the pelvic floor. Next set of muscles, okay, we're going to go into the next chart. So this is where things get interesting, and then these are more of the urogenital region. So we're going to shift from the uroanal to the urogenital triangle, and then we're going to start with the superficial layer first, okay? And I have the male-female just to denote the difference of gender. So for the female, for the bulbospongiosis, slight difference here. Obviously, the function is to keep the vaginal canal open, whereas for the male, it's mainly to allow the contraction and the propulsion, the peristaltic motion of the semen or urine. Okay, so slight difference. The tube is different, right? The female urethra is way shorter than the male. So that means the size of the bulbospongiosis will be also different. Okay, the O's and I's are the same, so I'll just give you that pinpoint. The origin is going to be at the base of the clitoris for the female, and for the male, it's going to be the penis. The insertion will be the perineal body. It's a whole area. It's a sheath that touches the whole area. So it's not one bone that it binds to, it's a whole area. This is also why usually ED, so when you think about, and maybe you've heard about this, or maybe you've hopefully didn't have to experience it, but when you have erectile dysfunction, as you progressively get older, and if you don't have the right musculature activation, there's variations of ED. Okay? When they assess for ED, erectile dysfunction, you measure the hardness of the erection. Is it going to be penetratable? So if you can penetrate and have intercourse, or if it's relatively hard but also non-penetrable, or if it's just completely non-penetrable. Does that make sense? So there's kind of stages or almost like a span of variation in terms of the hardness of your erection. And that could be because when you have a weakened bulbospongiosis, the muscle touches such a big part of the area that you might just have a section of it injured. And that may weaken a portion of the erection. Okay? All right. Next one, we have the east cavernosus. The main function is to assist also in erection and penis for clitoris erection. And then the O's and I's right here. The O is going to be the ischiotuberosity. The insertion goes to the pubis symphysis. So these are pretty clear bone markings. Okay, so this one's very clear. Also, pudendal nerve S2 to S4. They definitely work on the same side. I will probably say that the east cavernosus has a little bit more of the sexual function, whereas the bulbospongiosis plays a little bit more of the urinary function. And then the last one that is also going to be within the superficial layer is your transverse superficial perineum. If it has a word transverse, that means there's going to be another one that is going to be the deep one. Okay, so there's two of them. This one's main function is just to support the pelvic floor. Okay, so I didn't intentionally add any additional actions. So again, when you're looking at it, the ones that are just more supporting based, I just put the words or the phrase support the pelvic viscera, pelvic organs. The origin for the superficial is going to be the ischemous, the ramus of the ischium, and then also the insertion will be the perineal body. All right, so there's a little bit of overlap on the perineal body, and this is one of the major structures that, when compromised, when you do have a fracture or you have a injury to that region, then you compromise all the muscles. Okay. All right. Keep going. Next set of muscles. So within the deepest layer of the muscle, the main one I want to highlight that I want you to know is the EUS. Okay, the external urethra sphincter, and this is the one that constricts and dilates the urethra to allow the inhibition of urination. And when this muscle weakens, along with the other one, so levator ani as a set, and also this one, then you're going to just not have any kind of control for urinary incontinence. The ozonize are going to be, it wraps around the actual tube of the urethra. So this is also that tubular muscle. Okay, so this one on an image looks like a circle, but in the cross-section image, I show you the coiling, the long band of tubes. All right, let's take a look. Okay, so now that we went over all the muscles, let's take a zoom in and look at some of these muscles close up so you can see very clearly which one's which. Okay, so we are gonna, I'll have the cadaver images during the lab time, okay, but just use this cartoon image first, and every time we go over these images and anatomy, I want you to start with the cartoon, so you see the perfect, the prettiest version. Then when you see the cadaver, you're like, geez, it's very different, right? Okay, so first and foremost is we have two views. The left side of the view is superficial. So you take the scalpel and you prep the and then you've respected the donation. You're absolutely excited, and now you have the perineum opened up and you trim off some of the fascia and the fat. The first view here for the female. So we'll start with the female first. You'll see over here on the top part is the anterior, bottom part is the posterior, the uro triangle right here. Okay, and then we have the anal triangle right here. Oops. Let me zoom out a little bit here. Okay, there we go. Okay, and then over here within the first layer of the urogenital triangle, you can see the superficial muscle that you'll see is cavernosus. This muscle, and I'll use the green one, it actually spans on the lateral border of the triangle. So if you have a triangle, right, that triangle again, the lateral edge of the triangle is the is cavernosus. The one that's more internal, midline, will be your bulbar spongiosus, the one right here. Okay, so one way to always remember is if you're thinking about the muscle going from lateral to medial, you have is cavernosus, then the bulbar spongiosus. Okay, lateral to medial. And then where is the transverse perineum? It serves at the bottom. So the bottom of the triangle will be the transverse perineum, the base. Let me use another color because it might be a little bit easier. All right, so I'll use the orange to kind of draw the muscles. Okay, so the is cavernosus is right here on the lateral border of the triangle. The midline will be the bulbar spongiosus, and the base will then be the transverse perineum. So think of a triangle, and then you cut the triangle in half. Then you have the three little borders of these muscles. That's the superficial one. Okay, so that's what you should see. If you see a cadaver one day, or if you see a patient, and you think about the muscle layer first, that's what you see. And then you take that layer off, then you go deeper. Now you have the ability to see the external urethra sphincter. Now after the muscles are cut open, you can see the tubular muscles around the urethra. And then you can also see some of the different deeper transverse perineum. And basically this deep transverse perineum is a whole sheath. You guys see that? The orange line that I just marked, it's a whole sheath. It spans the entirety of that urogenital triangle. Okay? All right, and then let's go to the bottom. For the uroanal triangle, the major muscles that you can see will have to be deeper within, and you'll see the levator ani. Levator ani is basically pubococcygeus and elococcygeus together. Some books just use the word levator ani as a set. Other books might split them out into two separate muscles, but that as a group is the levator ani. Okay, and it spans, if you look at the picture, how does the fibers look? So if you look at this deep fiber, it doesn't just stop there. It actually goes all the way to the front. You guys see that? So these lines that I just showed, these four lines, they span all the way up to the front. So they overlap between the urogenital and the uroanal. Even though the levator ani is mostly on the posterior side in images, it spans all the way to the front. So that's why it plays a role for incontinence. Okay? And then over here on the very most posterior side, you have the coccygeus, that small one that supports the pelvic floor. Attaches to what? What does it insert to? The coccygeus? Looking at the picture, you don't have to recall. Just look at the picture. What does the coccygeus insert to right here? Coccyx bone, sacrum, right? So the tailbone, basically, right? Okay. And then over here we have the anal sphincter that surrounds the anus. Okay, right here. All right. And then again on the left side we have the gluteus muscle. So you would have to rip off the gluteus muscles to see the deeper layers. All right. So a lot going on. Okay. So we'll do this one more time. So you just saw the female. Let's do this one more time. We'll do it with the males now. Okay. So now imagine you have a male cadaver. Right? So we're gonna. It's always nice to just kind of walk it through. It's like a little tour. Let's go down a little bit. Oops. Okay. All right. So yeah, bless you there. And then over here, let's go ahead and do the same thing for the male. So on the bottom, again, we draw the triangle, urogenital triangle. We'll draw with the blue line. Uroanal triangle right here. Okay, and a couple muscles. So again, divide the triangle in half, split it in half. Now we have the three borders. So we have the east cavernosus on here. Let me use the color. East cavernosus here in green. Right, and then bulbospongiosis deeper within, and then superficial transverse perineum. Right, so you have the triangle within the triangle. On the right side, we go deeper. We're going to have the external urethral sphincter around the urethra, right, controlling urination, and then we have that entire flat panel muscle called the deep transverse perineum. Same thing goes for the posterior side, the anal triangle. We have the external anal sphincter after we cut off the gluteus maximus, so we have to rip that muscle off to see it. And then on the very back posterior side, we have that small little muscle that binds to your tailbone, your coccyx, your sacrum, the coccygeus. And then, of course, the main one that is comprised of two muscles, the pubococcygeus and neurococcygeus, is your levator ani. But it goes all the way from the back to the front. Okay? So it's good. I think it's good to look at it, right? And especially with anatomy, what I will definitely say is that when you're able to draw it yourself, so if you're still having issues finding a way to retain the anatomy, right? Because we're going through a lot of stuff, and probably, if you're a normal person, you're going to forget a lot of it. The best way to retain it for long term, and when you're getting to prep for medical school, right? So a lot of people are actually, crazy story is I have a student at Fresno State, and she is taking just an anatomy class just to kind of review. She's already getting ready to go to optometry school, and she just wants to keep the content fresh. And so most of you guys are probably getting ready for that as well, right? So you're probably coming to CHSU next year, and the goal is to keep the information so that when you go in, you're cruising your first year, right? You just got to fine tune a few things. You won't be nearly as stressed, okay? Because you're kind of distributing your stress levels out to this year. So draw it out, trace it out. That really helps if you need to find a way. It takes some time, but just when you're looking at these images, draw it out. If you have a tablet, draw on it. If you just don't have a tablet, use a paper, sketch it out. Okay? All right, let's do one more image. So this one is a deeper view. This one's nice because it shows you just the bone and the muscle by itself. So again, I want to show you in conjunction to the obturator internus, so the OI muscles right here. This is more external. You can see how it spans. And then which view is which? This is posterior, right? This is the sacrum and the tailbone. The pubic symphysis is over here. So in this picture, it's flipped around. Okay, so we flopped it around. Over here on the most posterior side, we have the piriformis muscle. This is the one that oftentimes hits the sciatic nerve. We went over that. But I want to show you the levator ani in close-up. So you can see the levator ani is the iliococcygeus right here. And then the pubococcygeus spans all the way from the tailbone all the way to the front. So if you look at this view, this is why it's very clear why if you were to have any damage to the levator ani, you're going to have a weakened urinary function and also weakened defecation reflex because it ties to both of those tubes, right? This is why, okay? So again, whenever you get a board-style question in your medical school first year, and I'll promise you'll see this, patient comes in with urinary incontinence and they have an issue controlling their bladder. which muscles are damaged in the pelvic floor? Levator ani. Okay, that just, there's a few of these where you got to associate with common injuries. You just got to know. Like 90% of the time, it's going to be like that. Okay, cool. All right, good. Let's do one more. Okay, so over here, another view showing you the male on top. So you can see the penis, and then the structure is a little bit more animated out. And over here, we have the urogenital triangle shown in green, uroanal triangle over here, and over here showing you the bulbospongiosis and ischiavernosis. You can see the shaft. So the ischiavernosis is on the lateral border, and then bulbospongiosis wraps around the shaft of the penis. Right, you can see that part of the penis. On the right side, when you rip those muscles off, you can see the external urethral sphincter around the tube very clearly, and then the anal sphincter. Okay, so I want you to keep this visual in mind, because when I show you the cadaver, it's definitely not nearly as clean. Okay, and on the bottom, let's take a look at the females, right? So we don't want to, now we go down to the bottom, and you can see over here, again, the female structures, the mons pubis, the eminence, fatty eminence over here, and then you have the clitoris, bulbospongiosis surrounding, ischiavernosis on the lateral edges, and then when you rip those muscles off, you can see over here the external urethral sphincter, and then the deep transverse perineal muscles. Very quickly, let me just refresh your mind on the rectum and the anal canal. This was from the session 2 weeks ago. So the rectum is part of the lower GI, and it's continuous directly with the sigmoid colon. It's going to lie right at the S3 vertebra. A few things I want to highlight here is there's a few key junctures and flexures that I want to pinpoint. The first one is your rectal sigmoid juncture. This is going to be right at the patient's S3 level. So if you were to look at an X-ray and you're looking at the S3 sacral 3 vertebra, so at the sacrum region, that's roughly where you're going to equate it to the sigmoid juncture to the rectum. Within the rectum, you're going to have a region called the ampulla. That ampulla is important because of the significance that it retains the fecal matter. So it's a pouch that curves, and this region allows you to accumulate the fecal waste, right? So that's why as the pressure builds up, the nerves signal, and then you have the defecation reflex. The anal rectal flexure is going to be the junction right here. So you can see there's a curvature. Again, it might not be exaggerated like this in every case, but you'll see a slight bend and then a change in the transition to different tissues. The slide that we covered that was really, and also on the quiz, right, was the transition of the different tissue types as you go from the different layers of the rectum towards the anal canal. And then over here, we have the 3 flexures: superior flexure, intermediate, and also the inferior flexure. Within these flexure regions, the pubal rectalis is parallel to the anal rectal flexure. So when you have an injury or a weakening of that muscle, the pubal rectal muscle, along with the external anal sphincter, then you won't have the ability to control the feces. You can't either expel the feces, or you're not able to maintain it up there. As a result, you then have the fecal incontinence. Okay, and then this is an image showing you zooming in a sagittal view with all the different venous plexuses, and then also the rectal arteries. So we have the superior rectal artery, middle rectal artery, inferior rectal artery, which I'll show you in the next slide. So for the 3 arteries, what we have is we have the superior part. So the superior part is going to supply to the proximal upper portion of the rectum. The middle and the inferior is going to supply by the right and left middle rectal arteries. And then what's important to make sure you're aware is the anal canal is supplied by the inferior anal rectal artery. Okay, so most of them just match up so that you're thinking rectum and then the word rectal artery. Right? They match up. Superior is the proximal. The middle is going to be the middle. However, the inferior is mostly in the anal canal. So just be mindful that there's a change in the structure. This is the same exact image that I showed you 2 weeks ago. So nothing too different here, just superior rectal artery on top, the middle rectal artery in the middle, and then we have the inferior rectal artery on the bottom. Notice right here we have the levator ani, bless you. Right, so the levator ani muscle, remember how I showed you right before the break, is that spans from the coccyx all the way to the pubic symphysis, right? It's literally longitudinal. It's going to be from the front to the back to the front. And if there is any compromising of that muscle, any weakening of these fibers, it's going to result in issues with the movement of your feces. All right, over here, we went over a little bit on the venous plexus. Exactly the same as the arteries, we have the external rectal venous plexus. The lymphatic drainage here, there's a few nodes that is of significance, mainly because you can palpitate them. So when you do the DRE, the digital rectal exam, in some cases when some of these lower lymph nodes are swollen, you might be able to notice a bulge. But the superior drainage is going to be your pararectal lymph nodes and also the inferior mesenteric lymph node. As you move down to the sacrum, lower towards the tailbone, it matches with the term. We have the sacral lymph nodes, and then we also have the internal iliac. Okay, so those are your main lymph node sites. Again, for this whole course, we didn't map out too much on the specific location of these lymph nodes, but just be mindful that as you progress down, there are certain areas where you can identify if there is swelling, and there's some areas where you just can't. Right? The accumulation of the lymph nodes are going to be a little bit uneven and asymmetric throughout the body. Okay, as far as the innervation goes, we have sympathetic, parasympathetic supply. This should be a quick review. So for the sympathetic division, where you have that fight or flight response, we have most of these nerves converging at the lumbar splanchnic nerves, and this is going to be through the hypogastric plexus. Okay, so those are the main ganglion neuron interventions. And then for the parasympathetic, it's all going to be S2, S4. Okay, nice and easy. You have the pelvic splanchnic nerves as well, and then the inferior hypogastric. So S2, S4 for relaxation. And this vision, I don't like this picture too much, but you can see just the interconnectionness. So when you have pressure build up and then your inferior valves begin to stretch, that's going to then distend this smooth muscle. There's going to be this natural peristaltic motion as a result of the tube, and then you're going to have the urge to want to relax the external anal sphincter. So what's keeping you from having a disaster in your underwear is going to be then because you're consciously activating that internal sphincter to be able to contract. But as the pressure builds up, you're going to have discomfort. And by the way, these valves also enable gas buildup. So that's why when you have gas discharge and you fart because of the accumulation of the waste, it's the valves allowing the waste to pile up. Okay, so that is the innervation. And over here, this is the DRE that I talked about a few times. There is actually a session where you're going to get a chance to practice this on one of the models in the medical school. So this is a common assessment tool. But what you'll see over here on the right is you'll have the glove, you'll have the patient lie prone and tilted to one side, and then you will basically take the finger, and about 1 to 2 centimeters in, you can palpitate around, but anteriorly, the three structures or the three items that you're looking for both male and females. For the male is prostate and seminal gland, so that's what you're being able to feel for any swelling. For the females, dilation for the cervix. Okay, so there's differences there. And then for the pelvic structures, on the pelvic posterior side, you could feel parts of the bony protuberance, so the sacrum, the coxum. And then you might, in parentheses, may be able to feel parts of the ischiotuberosities and ischiosplon. Okay, so that's why just that digital exam, that few centimeters with a trained finger, you could be able to know if there's any kind of swelling or any kind of potential fractures around those regions. Okay, and then this is oftentimes as a result of a positive test, you might have either inflamed lymph nodes, and the one that's most likely inflamed is your internal iliac, or potentially if you were to have a big and swollen prostate, what happens to your urethra? Right, so you're going to have a non-ability to pass urine, and the urine accumulates, and some parts of your urethra will be smaller, and some parts will swell up because the urine accumulates. Okay, and this is also why sometimes when there is tenderness, and in some cases you might even be able to get appendicitis, but this is kind of a rare case. But this is just the visual showing you. You go in, you get to the anal rectal flexure, and then you could palpitate for the prostate. You could palpitate for the dilation as well for the urethra. Okay, all right. We go next. We go into the kidneys. All right, so the renal system, real quick, is also going to be retroperitoneal in the lower GI, and then we have a couple structures we're going to go over. But the first part is knowing what innervations and blood vessel supply. There's a lot of 25% plus of the blood flow is constantly going through the kidneys for filtration, and the structure of the kidneys is just like the lymph node. So that 2 weeks ago when we went over the lymph nodes, very similar anatomy. We have the outer cortex, inner medulla, the hilum, We have the renal pyramids. We also have the calyces, the major calyces, minor calyces, and then we have the ureter that drains in. So let's go into the blood flow first. So in order for the blood flow to get to the kidney, you go through the bigger arteries and you drain into smaller arteries. And the end goal in the kidneys is the ability to do the filtration process. The microscopic unit of a kidney is called a nephron. Within a nephron, there's several tubes, and there should be a little bit of overlap with some of the content you're going over, but this is the three segments of the tubules that you got to be aware of: the PCT, the loop of Henle, also known as the nephron loop, and then the DCT. There is a difference in the kind of tissue that you'll see at different sections. So mostly in the PCT, you have that cuboidal type tissue. Majority of all absorption of nutrients, protein, ion, sodium chloride, they're all reabsorbed in that region. Most of the water is also reabsorbed right there. And then you transition to the loop of Henle. Do you guys remember what's the significance of the loop of Henle? The descending versus ascending limb? Which side is permeable to water? Which side is permeable to sodium and ions? Descending is permeable to what? So to which one? Sodium and ions or water? Water. And then what about the ascending limb? So what happens? What happens in the loop of Henle? You guys go over this? Oh, cool. Okay, so what happens in the loop of Henle? What's the significance of that unique one side that is impermeable to water and one side that is permeable to salts? What does that create? Huh? Gradient, you're right. So you're going to make an area to hyperconcentrate all the waste, the urea, the solutes, and that's going to pull water out. Right? So that's a little, what they call the countercurrent multiplier. You guys go over this? Countercurrent multiplier, countercurrent exchanger effect, where you create this crazy gradient to draw out water. As one side feeds ions, the other side pulls water. So that's another absorption of fluid, and you hyperconcentrate the urine. So as urine is forming, okay, so just real quickly here, is we're talking about urine and incontinence. As the blood enters in the afferent arteriole, you have this glomerulus. The glomerulus, this big bulb that serves as a filtration apparatus. You have the podocytes and these foot cells that will filter out the size of different debris. Certain proteins that are too big, like albumin, and certain red blood cells, they can't get through. If they do get through, that means you have blood in the urine. Then we have the efferent arteriole that leads back out, and then around the tube that's not shown in the picture is a set of capillaries called the perivascular capillaries. And these perivascular capillaries are going to retain all the water for your body. As you go into the loop of Henle, and you go from descending limb to ascending limb, you'll see right here that the tissue is different. The thin descending limb is a lot smaller and more narrow. And then when you ascend up, it's a little thicker. So you have this one side that allows the permeability of water, and the other side allows salt to pass through. So as the salt drives the water out, you have more osmotic pulling of water, and then you concentrate the urine as you go down. So the urine in this tube at the lower parts of the loop of Henle is hyperconcentrated, right? Because that means all the water has been pulled out. It's very, very dense. It's very, very concentrated with all the waste. And then as you go back up, you have the collecting ducts and the DCT, and this is where most of the hormones apply. So when we hear about aldosterone and ADH, they target the water channels to reabsorb water, and then it comes down to the collecting duct. So again, just make sure you are aware of the different sections of the nephron and as far as anatomy goes, and then make sure you know that there is a transition from the more of that cuboidal tissue down to that squamous, thinner, and then back to cuboidal. Okay. All right, and then over here, let's go over the blood vessels. So the vasculature is straightforward. So there's a pattern of flow. So as you enter in the kidneys, we go from the renal arteries, the main delivery of blood in. We go into the first branching called segmental arteries, SAs. We go into the interlobar arteries. Then we make a curvature around each of these renal pyramids called the arcuate arteries. And then they radiate into the deeper arteries, and they eventually pass into a nephron. Once you get into nephron, then we're in the afferent arteriole. So this is the nephron level. And then all of the blood vessels, which are capillaries that allow you to reabsorb the water, are going to be your vasa rectus, your perivascular capillaries. Okay? And then it goes back out and then retains through the veins. So this is the flow. It's going from the large to the smaller arteries. So make sure you are aware of the flow. I think this is, you guys cover this in physiology? the blood flow, or you guys only went over the different? Just a little bit. Okay. So we have renal artery. That's the main one. So right here, let me show you the map. If you watch the picture here, I'll use the green arrow as a blood. So renal artery comes in. You're going to come in, and you're going to branch off to all the different sections of these renal medulla. So these inner part are the medulla, and these renal pyramids are shown here like a reverse triangle. These deeper parts are where urine gets concentrated, and they look like little fibers, but they're not muscle. These fibers are the tubes. Right? So your kidneys are composed of millions upon millions of these nephrons. Nephrons are a drainage system. You have a glomerulus, a PCT, a loop of Henle, a DCT, and a collecting duct. As the blood goes in, the goal is to filter whatever you don't want out of the blood, retain as much fluid. So every time the blood passes through your kidneys, you're retaining like 98% of the fluid. But however, you have this bare baseline GFR where every minute, every time the blood passes through, you're losing some fluid. Right? You guys probably went over GFR, glomerular filtration rate, and you have like a standard rate for assessing kidney health, like 125 ml or so. But again, when your GFR goes down, that means your kidney function is going down. Okay, you want to maintain healthy filtration. And then it curves into the interlobar arteries right here, passes into the arcuate arteries, and it goes in, which you can't see in the picture, the afferent arterioles. These are too small to see, and they then go into the nephron. Okay, so that's the passage. I'll have actually, this is a better image. Let me use this slide. This is a better slide. So on the right side for the blood flow, so this is something you should know in terms of the passage. Renal artery is the largest artery going in, segmental arteries, interlobar arteries, arcuate arteries, radiate arteries, and then now we have the nephron. Okay, everything in the bottom rectangle are going to be in the nephron. And then we go from the afferent leading in, efferent, letter E for exit. Okay, so A starts the alphabet, so A begins the passage in. Efferent with the letter E, that's the exiting of the nephron. And it goes into the vasa recta, the peritubular capillaries. All the stuff on the bottom is in the nephron. These are microscopic. Then we go to the smaller venules. Again, over here matches perfectly. The cortical radiate veins, just like the cortical radiate arteries. The arcuate vein, just like the arcuate arteries. Interlobar veins, interlobar arteries, and then the renal vein. The only one that we don't have, in some cases, some books omit this, is you don't have the segmental veins. Everything else matches perfectly. Okay, so if you know half the story, you're pretty much good. So as far as blood flow to the kidneys goes, it's one of those anatomical memorization pathways. It's like a map. You know how it goes in, how it goes out. And then as far as the key innervations goes for the kidneys, it is under the control of autoregulation. So that means you have the myogenic response, the stretching, the amount of blood flow going in can control how much blood is going to then pass by. It also receives sympathetic nerve innervation through the celiac and then the inferior mesenteric ganglia. And this is through the renal nerves. Okay, so it does have the ability to stimulate when needed the amount of blood flow by controlling something called the RAS system. And I'm almost certain you guys have gone over that, right? RAS, the renin, angiotensinogen, angiotensin 1, angiotensin 2 system, and eventually aldosterone. Okay, so the renin is stimulated by the maculodensa cells inside the nephron, so that's the sensor cells. And then here we go. Right, so over here, as far as the ureters go, so passing from the kidneys, we're going to then form the urine, and the urine gets condensed down and drains into the ureter. This is the tube that carries the urine down. And within the ureters, this is the exiting out of the hilum region. You're going to be able to pass down all the way to the bladder. However, there is going to be this trigon area. This is the entering to the bladder. So the trigon is a triangular passageway where there's an opening for the orifice for the urine to come in. The ureter does contain, a ranging length for about 25 to 30 centimeters, depending on height of the individual. There's also smaller valves embedded within, so it makes sure that the urine does not reflux. There is an inborn congenital disease where the ureter is actually flipped around, where the kidneys are actually going to be inverted, and as a result of that, the urine backflows, resulting in a lot of kidney infections and kidney stones. I forgot the name of that, but it's a very rare congenital defect where the kidneys are reverted. And then as a result, the ureters have this natural peristaltic motion to squeeze and discharge your urine. Okay, so the ureter, over here on the right side, I want to show you the vasculature first, and we'll have this again, but let me show you the difference here. So for the males, again, there's slight variations, right? So this is why it's actually kind of nice to be mindful of this, is as we're going through the perineum and then going through the reproductive system, the males and females will have small differences, and it's good to note them. For the male, we start on from the lower inferior vesicular artery. For females, it goes from the vaginal artery. Okay, so again, males, inferior vesicular, females, vaginal artery. That's the smaller branches at the lower side to the lower parts of the bladder. We then share the middle rectal artery. The males and females both share them. And then as you move further up, we have the uterine artery. This is a little bit higher up in the chain. And then we have the superior vesicular artery for both males and females, internal iliac. So out of this list right here, the two arteries that you should be mindful of when you go into the reproductive system that females have, that males don't have, will be the uterine artery, right, to the uterus, and also the vaginal artery. For the males, we have the inferior vesicular that goes to the lower gonads, testes. Okay? So those are structures when you're reading a question, and for those being the choices, you should be able to identify the gender. And so what kind of gender are we looking at? What kind of blood supply does that patient have? The ureters eventually drain into the bladder. The bladder is supported by several structures. We'll go into that in a second, but you can see right here the two tubes of the ureter coming in, and they pass on the posterior side into a region called the trigon. The trigon is shown here on the bottom. It's like a triangular region where there's two orifices, the ureteral orifices where the urine drains in. The ureter and also along with the bladder shares similar histology. We have the intermucosal layer, just like the GI system. However, the tissue is important. It's transitional. Anybody know what transitional epithelium looks like? So there's squamous, cuboidal, columnar, pseudostratified, and then of those four, there's simple and stratified, right? Simple is one layer, stratified is multiple layers. What's transitional? Transitional is like a blend between squamous with cuboidal. It's like mixture. Literally, you're going to see some squamous looking cells and some cuboidal. So that's why it's transitional. It's very unique. It has the ability to stretch and change and distend quite a bit. So in the intermucosal for the bladder and ureters, it's mostly transitional. Okay. As you go into the middle layer, we have the smooth muscle. So that longitudinal and circular muscle. And then adventitia is going to be the outer fibrous capsule that is directly extended through the peritoneum. On the bottom here, this is a male or female that we're looking at. Male, right? So we have the prostate right here. Notice over here, when the prostate enlarges, that's going to then cause a restriction of the passage of urine, causing the lower parts of the urethra to distend and squeeze down a little bit. And then the bladder gets bigger, so then you stretch out the bladder. So let's take a look at the tissue. So this is what transitional epithelium looks like. It's very unique. But if you zoom in to this image here, you'll see that throughout these tissue, right, where I circled in red, some of these are a little bit longer. The nucleus is a little bit stacked on some of the sides and the corners. There's some that seem to be a little bit more full. But when you see the ureter or bladder tissue, a biopsy of the ureter or bladder, these tissue are transitional. It's a very unique, this is not the best zoom, but if you zoom into them, you'll see it's very unique. It's like a blend of squamous and cuboidal. You might even at one point think it looks kind of cancerous because of just the number of nucleuses packed together. So that's a visual that I want you to be mindful of. All right, and then as far as the vasculature goes, the ureter supply comes from the common iliac, then branches down into the internal iliac. And then for the females, we have the ovarian arteries. And then for the males, we have the inferior vesicular. Okay, so I highlighted that already. So the ovarian and the uterine go together. These ones are smaller. We'll go over to this on the reproductive system, so I'm not going to spend too much time going over these ones. And for the males, we have the inferior vesicular. Okay, I'll show you some more visuals, and the way you can imagine this is that you look at the sagittal view, you have the common iliac comes down, and then it makes a curvature. It makes a curvature. So from the posterior towards the interior, it branches from the sacral artery to the rectal artery, then to the uterine artery or the inferior vesicular artery, and then go to the pubal artery. So it kind of curves all from that common iliac and then eventually the internal iliac. So these are all sub-branches from the internal iliac. They then branch off of it. Then the lymph nodes are going to share common internal iliac nodes. So again, a lot of overlap in terms of the blood supply in the lymph nodes. Okay, all right, keep going. As far as the innervation goes, you'll see that you also have the sympathetic and parasympathetic division. Sympathetic comes from your T10 to L2. And then for your parasympathetic, again, S2 to S4. So the main plexuses are the renal plexus, parts of the superior and also the inferior hypogastric plexuses. And this picture is actually not bad. If you look at the picture, these yellow kind of nodes that you see right here are just showing you around these main arteries, you have like a lump of nerve tissue. And these plexuses are the main neurons for the sympathetic division. So on the top, we have celiac ganglion, superior mesenteric ganglion, we have the inferior mesenteric ganglion, but these three are probably the main sets of your sympathetic nerve fiber. You can't really see this well on a cadaver. So this is one of those images where I think the cartoon or the kind of artificial perfect views are not bad. So if you were dissecting a cadaver and then you get to the renal artery, you know about an inch or an inch and a half above that, you should anticipate the celiac ganglion. Right around the renal artery is where you're going to find the superior mesenteric ganglion. Okay, so that area is where all those nerves accumulate. All right, so let's keep going. So now for the bladder, a few things for the bladder is we have several ligaments that uphold the integrity of the bladder. And of course, for females, it can be a little bit different because you have the uterus sitting on top of it. But you have the two main ligaments, the medial or median umbilical ligament. This extends from the anterior region of the bladder all the way to the superior border. So you can see right here, median. And then we have the lateral that goes from the lateral edges of the umbilical. And these are the four main suspensions that you have for keeping the bladder upheld. Over here, we have the median right here, essentially. So the ureters, combined. There's another section that's cut off in the back. But as a result of this, for the males, most of the time, the base of the bladder is going to sit nicely between the pubic symphysis and the rectum. So it's nice and tugged. But because the females have the uterus, it might get kind of squashed down a little bit, but sits a little bit more towards the interior of the vagina. Okay, so it bends down. That's also why when you are pregnant, what happens? What happens when you're in your trimester? And then you're pregnant. You're almost due. Well, how does your urinary frequency change? A lot, right? Because you have this infant sitting in and on the bladder, right? So your bladder volume is squished down, and so you're constantly having discharge of urine. Okay, and I think I have a picture for that. Pretty simple to look at, but over here, just showing you. Right, actually, this is pretty good. So you can see the snapshot of the sagittal view of the male and female, and we'll go over the reproductive structures towards the end, so don't worry too much about this image right here, but I just want to show you the bladder. So for a male, you can see that the size of the bladder is very, very open. It sits right on top of that prostate, right anterior to the rectum. For a female, the bladder size is way smaller, and then when you have that uterus developing, it compresses that even more. Okay, so there's substantial differences. The bladder, like I said, is held by that main lateral ligaments. There's also that tendinous arch of the fascia. When you divide the bladder up, just like your heart and your lungs, you also have the apex on top, the body, the fundus, and the neck. So these are general anatomical terms that we use for many structures. We went over this in the stomach, right? The fundus, the cardia, the body, the neck. So there's a lot of overlapping regional terms. So I'm not going to spend too much time on that. One thing I do want to point out is surrounding the bladder, you have a thin layer muscle called the detrusor. And this allows you to maintain that kind of peristaltic motion. So when you're urinating or when you're expanding the bladder, you can limit that volume to some degree. And again, on average, if you realize when you hold 500, 600, 700 mLs of urine, you're dancing, right? You're going to be in very big discomfort. And that's why I think that there's some kind of article said that when you're driving with a full bladder, that's almost as dangerous as drunk driving. When you need to urinate and you can't stop to urinate, your whole body kind of goes into a very unstable state. Okay. All right. So over here, I do have a clinical application. So for a clinical application to this is that because of the enlargement of the prostate as you get older for males, oftentimes the vulva might be a little bit more prominent, and that region of the bladder could be distended. So on an X-ray or when you do like a the checkup, you could be able to visualize it because of an enlarged prostate. And of course, now we have PSA. So PSA goes up, that means your prostate probably is inflamed, there's something's going on. As far as the vasculature goes, for the males, we have the inferior vesicular arteries. For the females, vaginal arteries, and they're all branches of the internal iliac. Okay? So there's one main blood vessel to be mindful of. All the rectal arteries, all the sacral arteries, the small branching to the uterine, ovarian, it's all coming from the internal iliac. All right, keep going. And then as far as the innervation goes, the sympathetic division is mostly from the T11 to L2. In some cases, they might even have L3 in there, so I just put the L2, L3. The pain fibers primarily come from the superior parts of the bladder. So when you feel the discomfort, earlier when I was saying when you're driving with a full bladder and you feel pain, and you're like, oh, I can't do this anymore. I'm going to pee my pants. The pain trigger is from the superior aspect of your bladder. That's where most of the pain nerves come from. And then that region directly sends signals to that T11, L2 to then cause you to have the sensation of pain. The parasympathetic region is going to be from the S2, S4. Inferior region is mostly going to be from the parasympathetic division of inferior border. So you have both sensitivities depending on what's triggering your discomfort. And if you're in a fight or flight response, there may be a chance, right? You might get scared and startled and you discharge urine. All at the same time, if you're really calm and relaxed, you can also discharge urine. All right. And then for the male urethra, a few things I want to highlight. And this is the exiting, right? So now we pass over the bladder. We're going to exit the urine. You're going to have a couple of subdivisions for the male. And it's a little bit longer, right? You have 18 to 20 centimeters versus a portion of that. And as a result, for the males, there's a higher tendency to get UTI. For females, there's a higher tendency to get UTIs. Males, a little bit lower. But subdivided into the three divisions of the urethra: the prostatic, right around the prostate region; the membranous urethra, right around the membrane of the smaller gland; and then the spongy, which is going to be right by the tissue of the penis. Most of the time, what you're going to see is that the tissues do transition as well. Okay? They actually change. This is another example, just like we went over the rectum, where there is going to be a transitional of difference of tissue types. At the bladder head, or at the base of the bladder, most of it is going to be transitional epithelium, just like we said. As you move down further, you're going to be able to notice that some of the tissue begins to be more stratified columnar. More specifically, there's also a little bit of that pseudostratified appearance where they're collapsed and elongated. Some nuclei are not going to be at the same level. And then at the final stage, at the urethral opening, where the urine comes out, you have stratified squamous. Okay, so a general kind of transition to be mindful of is it goes from transitional epithelium to columnar to squamous. And that happens as you go from the base of the bladder out through the urethra. Anybody remember how it transitions in the rectum? And it becomes stratified, right? So simple becomes stratified, and then stratified squamous, right? Yeah, so again, it's very similar. So it goes from that simple to stratified to squamous. Over here, transitional, columnar, then squamous. Okay, and this is important because when you do a biopsy or if you're assessing the tissues of these regions, it's very different from wherever you take it. Okay, all right. I guess we're good here. You guys have any questions on the male part? Let's do the female real quick, and then we'll do the questions, or if Lewis is ready with the polems, we'll get that going. All right, over here for the female, comparison is 3 to 5 centimeters, and then we have the external urethral orifice on the interior wall of the vagina. Again, I'm not trying to overload you with too much content, but you can see very clearly the uterus snapping over the bladder, and then you have the pubic symphysis right here. So when you have an infant in trimester developing, the amount of size that you would have of the bladder is very limited, right? And then, of course, the clearance is a little bit lower, so there's a higher chance of UTIs and infections fast track. Okay. All right. So that's it for the content. Any questions? You good?